Welcome to the presentation on palliative care, highlighting on the benefits of early referral and the underutilization, presented by Sydney Makenberger for Fort Hays State University. In the healthcare industry that our current medical care structure is inadequate in meeting the needs of terminally ill patients and reducing the cost of care at the end of life. And despite the fact that palliative care and early referral is proven to decrease patient symptoms, increase patient satisfaction, and decrease hospitalizations and ER visits, physicians and patients are reluctant to use this service. So why is this an issue? Personally, because I work in the field of oncology, almost 100% of my patients experience some sort of symptom or side effect and would greatly benefit for closer monitoring and management of symptoms that would lead to increased quality of life and decreased hospitalizations or ER visits. Nationally, there has been significant advances in understanding the benefits of early integration of palliative care in conjunction with disease management. And so many people living with chronic life-threatening illnesses, not just those with an oncology diagnosis, do not receive any palliative care services, or they receive these services only in the last phase of their illness. And so it is a healthcare issue because despite this, we are not providing the best care to our patients that we really could. In 2016, cancer was the second leading cause of death in the United States behind heart disease. And in 2017, the American Cancer Society projected that almost 1.7 million people would have a new diagnosis of cancer, and there would be almost 601,000 deaths. And so, despite these large and climbing numbers, the National Cancer Institute still only allocates 1% of budget onto palliative care research and education. Therefore, our patients and our physicians and our nurses do not receive research or education on this topic and on this resource and intervention. So we're lacking in providing it to our patients. There's a stigma that palliative care is hospice. And so the difference is that palliative care is an interprofessional discipline that aims at improving the quality of life of patients with advanced diseases and their families by addressing symptom concerns. And so this differs from hospice because hospice is medical care for disease without a cure with less than 6 months to live. And so you can have no curative treatments such as radiation or chemotherapy. And this specialty of palliative care has evolved very quickly, and their initial mission was centered on terminal cancer, but now it is thought and research that it should be applied as early as possible. So we all know those perceptions of palliative care that we hear, and it's not just our patients, it's also our nurses and our physicians because they just have not been educated about it. A study based solely on the perception of palliative care before treatment and then those who did not have treatment had the overall consensus that it was a negative thing. It was an end of life. It brought up fear and avoidance. It brought up resentment. People related it to death and hopelessness regarding their diagnosis. And many even termed it as good death and good dying. And so by the end of the study, those patients who had received palliative care understood the true benefits, and many made the same suggestion that the name palliative care needed to be kind of revamped and renamed to kind of rid the stigma, because they really did feel that the palliative care team was an advocate for their health care. They made them more comfortable, and they had an overall improved quality of living. And so we need to get rid of this perception that palliative care is bad and kind of integrate it into all of our patients, not just those with a cancer diagnosis. So what can a palliative care team do for our patients and our caregivers? They address the four main symptoms or main categories of physical, emotional, financial, and spiritual. So our patients experience pain, nausea, shortness of breath, loss of appetite, and with those things, they need treatment for it. They need medication, they need physical therapy, they need insure, or they need physical therapy. They could utilize support groups or counseling to deal with the emotional aspects of fear, anxiety, and depression. There is the financial burden, which no one wants to think about, but it has to be paid for. And the collaborative team of palliative care has all of these things. They can help you with medical jargon. They can help you with short-term disability forms and insurance. You build the early involvement of palliative care to deal with, these problems of anxiety and depression and the loss of hope allows us to build relationships with our patients and the palliative care team, and it just really facilitates many, many important discussions. And so when we can combat these symptoms early on, we decrease the pain and we decrease the anxiety, and our patients can live a more normal life. We can help them reach a better normal for them, or an improved baseline. So an early referral does all these things. Like I said, it helps develop a therapeutic relationship. And the early involvement and the clinical visits with the palliative care team allows detection of symptoms such as pain and depression through routine screening, and the early intervention and the patient education that comes along with this early detection can reduce the risk of symptom crisis, which would lead to ER visits or hospital stays. And so when we decrease those symptoms, we have an increased patient satisfaction, we have an improved quality of life, we have a decreased depression and decreased hospitalizations. And with decreased hospitalization leads to reduced cost and improved end-of-life care. And end-of-life care and end-of-life discussions is something that no one really wants to have. But when we have a palliative care team consult on board, that is something they try to discuss from the beginning. That way, when the time comes for end-of-life care and end-of-life decisions, our patients have made those decisions. They have talked this over with their family members, and it's not a big surprise. They are prepared for it. We are making sure, and we know we are carrying out the patient's wishes, which leads to an improved end of life and overall improved quality. And since we can provide palliative care in conjunction with oncology treatment, we can improve the care that we provide for our patients, because we are allowing them to have both the comfort care and the curative treatment that many seek. Cancer studies show that patients who reported having end-of-life discussions early on improved medical utilization in the last week of life. And so in the last week of life, patients kind of have agony. They go through that really shortness of breath. They have a lot of pain, or they go in and out of a lot of consciousness. And so if we have not had those end-of-life decisions, we can overutilize medical resources and endure a lot of cost on our patients. So we can help them by knowing what they want and having these conversations to decrease ICU admissions, decrease ventilator use, and decrease resuscitation. Because if we make their needs known to medical professionals and those taking care of them, they can pass in the comfort of their own home, or in the hospital, or in a nursing home, whatever their wishes to desire. We can make that happen. And so when we do this and we follow through, we have improved satisfaction and improved end-of-life care for our patients, and overall decreasing costs. And so cost is a really big thing, and so it's proven that when we manage our symptoms and we manage the pain and we manage the nausea and we have all these clinic meetings and we're kind of checking in with our patients more, that decreased ER visits and decreased hospitalizations did occur. So in one particular study, only 36% of patients who received palliative care had extra hospitalizations, and 59% of patients with just standard care had extra hospitalizations. Excuse me. So we're having a huge deficit there that we could keep our patients out of the hospital. We can treat them at home with IV nausea medicine and IV fluids and IV pain medicine if needed, and keep them comfortable, so they're not having to go to the ER and pay that big ER bill and overuse medical resources because they think that that is their only hope. But it also helps our caregivers. And there was a study done on the benefits of early versus delayed palliative care on the caregivers. And so many of our caregivers can actually endure more stress and more anxiety than our patients because they're kind of taking over. They're caring for the patient. They're also taking over more responsibilities in the household, which can lead to greater stress. And so those caregivers who had early palliative care referral had lower depression scores. They were able to report decreased symptom management in their family members. They were provided emotional and spiritual support, which can help decrease that stress burden and help decrease depression. And it allowed for help with personal care, activities of daily living, transportation, and the continuity of communication with the care coordinator, which led to higher quality of life. And so, our palliative care teams are also aiming to reduce distress and burden to our caregivers by educating them about what can go on and what to report and how to care for it and what is to come. And, we really want to provide our best care to our patients. And so we can't do that if we're not also caring for their caregivers. Their caregivers need to be in good health, and they need to know what to expect and in the right mind and in the right attitude to assist our patients. And so the World Health Organization adheres to the belief that palliative care is intended for all the seriously ill, not just the actively dying. They're kind of trying to break down the stigma and the modern protocol of treatment when it comes to oncology care, so that palliative care can be in addition to hospice care services. We can provide this service prior to needing hospice to and extend, the life frame for our patients. So one of the big issues that physicians and nurses do not receive adequate palliative care training, and it's not provided in undergraduate education or continued education unless that is one that you choose, to learn about. And so as a result, many nurses lack sufficient knowledge and competency about palliative care, specifically about, what they do, how they can help patients and that decision making, and what the referral process is like. And ultimately, I think that if we would train our nurses to use palliative care, their lives would be a lot easier. Because despite education and training, we play a pivotal role in engaging early palliative care. We're kind of the front line, and we need to communicate with our patients and our families all of their options, and we need to talk with our physicians and educate them about palliative care and about this integrative therapy, this collaboration of people that are here to help our patients and to make our jobs easier as nurses and physicians, because we can only care for them when they're under our roof. And so we want to know when they go home, they're being followed closely, and they're being followed to prevent the same crisis that possibly ended them up in the hospitalization in the first place. And so we can, as nurses, communicate with our patients and assist those patients and caregivers to a more comfortable journey, so they don't feel like they're alone and that they're the only people going through this. We kind of lead them in the right direction. this issue of not using palliative care and not knowing what palliative care is leading to us not providing our patients with the very best care possible. And we learn all the time that we want to base our care off evidence-based practice. And evidence-based practice is saying that we should implement palliative care referral at the beginning of a diagnosis because of what it does, because it improves quality of life and it improves mood and it decreases symptoms and it increases end-of-life care and it decreases cost. And so, the next step really is increasing availability, is having nurses become palliative care specialists, having physicians refer to a palliative care team, and more people really understanding the need for palliative care. And then once we kind of combat that, especially for the oncology world, I truly think this can expand. We can help our CHF patients and our COPD patients and our lymphedema patients who go through the same issues, who have the same physical, emotional, financial, and spiritual concerns that our oncology patients are having, that are having more and more hospitalizations and readmissions because they are kind of getting lost in the cracks. And so references that I used, lots of studies are being done, and they continue to do more research on palliative care and the effects it has, and how great it is, and how much of an intervention it is for our patients that we need to be utilizing. So thank you for taking the time to listen. And I know I'm a little long-winded. I'm just very, very passionate about palliative care, and I am trying to integrate it more into the practice that I currently work at. And I hope that you guys will take the time to kind of learn about it and ask around your hospitals and see what kind of palliative care options you have for your patients.